Welcome to the show. Today, we're going to talk about immune checkpoint inhibitors and how we need to think about these drugs a little differently in the emergency department because they're a little different than the normal drugs, the normal chemo drugs that we're used to. And we have to manage them a little differently. So my guest is my favorite heme-onc doctor of all time. We were interns together. Devi, why don't you introduce yourself?
Sure. Thank you so much. Happy to do this. My name is Devi Sampat. I am currently a third-year heme-onc fellow in Birmingham, Alabama at UAB, and I'm here to answer any questions that might help for emergency room physicians and really any doctors who might find this talk interesting.
Sweet. So why don't we start by just talking about what are immune checkpoint inhibitors and how do we know that a patient's on them?
Yeah. So immune checkpoint inhibitors have really changed and altered the oncological field by volumes. And what it really is asking for the body to do is very different than conventional chemotherapy, which is targeting pathways that these cancer cells can evade. But what immunotherapy does is it works with your immune system. So the easiest way that I kind of describe it to my patients itself when I'm telling my patients about it is this is a drug that is going to tell your immune system to turn off the brakes that the cancer cell put on them and actually open up to rev up the rest of the body to then go ahead and be ready for those cancer cells. So cancer cells can actually target our T cells and tell the T cells to shut off their immunogenicity. And that can wreak havoc on the rest of the body because it can't recognize the cancer cells. Well, what immunotherapy has kind of neatly and craftily done is it's pretty much said we're going to basically block the block and open up the immune system greatly. So they're wonderful drugs. We first started using them in the cancer world in about 2011 for melanoma, but now we use it for almost every single solid malignancy, and we're trying to use it for some of our liquid malignancies and lymphomas as well.
So literally almost every cancer, lung cancer,
yeah,
colon cancer, everything.
Yes. And we really actually tend to veer towards these drugs and appreciate these drugs more because I can't say this enough. These drugs are not like our conventional chemotherapy where you get really sick, you lose your hair, you have cytopenias and all your count drops. These drugs, because they're just kind of an immune system rever, can cause its own toxicities, which is, I think, why we're focusing on this today. But they don't do the harmful stuff. So we tend to use these drugs for our patients who are older or functionally declined because these patients can be on these drugs for a long time and do really well.
Okay, cool. So what are some of these drugs? How do we know when a patient's on this? Because from my perspective, it's like everyone's on some sort of drug. We lump them all into chemo drugs. There's a million names. And I never know which one's which, and
Yeah. So the names are going to be difficult because there are brand names and there are generic names. And it's not even like immune checkpoint inhibitors fit in a nice realm where you can say it ends in something like some of our other drugs, right? Because pembrolizumab, one of the most common ones, has a brand name Keytruda, which a lot of people have often heard about. And it does end in a mab, pembrolizumab. But we have other drugs like rituximab that are used both in the rheumatology world and in the benign and malignant heme world, which is actually not an immune checkpoint inhibitor. So I think the best way when you're in the ER or when you're a physician kind of in primary care, wherever you are treating these patients, is oncologists have been really trained to coach our patients and tell our patients, hey, this is not chemo, this is immunotherapy. And so the patients usually know themselves that I'm on something a little bit different than chemotherapy. And the savvy patient knows when to tell you, hey, I think I might be having an immune checkpoint. I'm using those interchangeably. So immunotherapy, immune checkpoint inhibitor. I'm using a immune checkpoint inhibitor drug for my cancer, and you need to know that it can cause these toxicities. And I'm worried that I have this toxicity today.
Gotcha. Okay, well, let's assume this is a typical day in the ER where nobody knows what meds they're on or whatever. What are some just basic names of some of the, like, probably the most common checkpoint inhibitors that are being used? Keytruda.
Keytruda. There is a drug called nivolumab or Opdivo being the brand name. I tend to see that patients tend to know usually the generic name. So they'll know pembrolizumab, they'll know nivolumab, and then another common one is ipilimumab. So these drugs can be used, as I said, for a lot of different cancers. When these drugs are sometimes combined, where the toxicities can actually be higher, are usually in metastatic melanoma or some stage of melanoma, as well as our kidney cancers, so renal cell carcinoma.
Okay. Well, I was going to ask, which cancer patients are getting these drugs? And it sounds like what you're saying is pretty much almost everybody.
Almost everybody can. For some cancers, it's used in more of the second line, third line, because the conventional chemotherapy that we have, we just know is better. But when those patients progress on that chemotherapy, then we tend to use immunotherapy because the chemotherapy has already kind of slammed their body. They're not in a space where they can get more chemotherapy. And we try to challenge them with immunotherapy, which they can do well on for a long time. So the most common person that you're going to see hit the ER on immunotherapy is probably a melanoma patient, a kidney patient, or a lung patient, I would say.
Okay, cool. All right. So what do we need to think about in regards to these drugs when someone comes into the ER on one of these drugs or to the clinic or wherever?
Yeah. So because the immune checkpoint inhibitors will rev up the immune system, what we need to think about is any sort of itis, any sort of inflammation in the body. So pneumonitis is a big one. If someone comes with shortness of breath, a lot of ERs, a lot of oncology centers until recently would think of the common things being common, like pneumonia. Right now, COVID. And those types of things certainly need to be ruled out. But one thing we need to keep higher in our differential is pneumonitis. Another thing is colitis. So it can cause very, very bad diarrhea. Our grade 3, grade 4 diarrheas that we say with immune checkpoint inhibitors can be a person going 7-8 times a day. So colitis. Dermatitis is also a big one. Somebody coming with really any type of rash that honestly onset was pretty quick. So dermatitis is a big one too. Some of the less common ones that we see are things like sialoadenitis, hypophysitis. We don't see those as much. I think we miss some of those, but I think for an ER physician, the big ones not to miss or to at least consider in the differential or consider calling up a heme-onc consult would be for pneumonitis and colitis.
Okay, cool. Yeah, I mean, so basically it sounds like you're ramping up the immune system and almost the side effect or the adverse effect is an autoimmune presentation of some sort of autoimmune inflammatory process.
Right. And one important thing to note is that, and patients who get this are being told this over and over again by us oncologists, which is that this can happen after one dose. It's not very dose dependent. It can happen after multiple doses. It can happen when you're off of immunotherapy. So that can be super tough, right? So because somebody can come in off of immunotherapy and have a C. diff, but it's important to just keep in the back of your mind that you also have to think about C. diff and immune checkpoint related colitis.
Well, how long after they're off? I mean, it can't be like 10 years ago I took this drug and now I have.
Yeah, 10 years would be rare. We don't know how long these drugs actually affect the body. But the short answer to your question is, while we don't know how long someone could have these toxicities, we think based on our studies that the drugs are out of the system by about the 2-year marker.
2 years. Wow. Okay. Yeah, I mean, it's interesting you're mentioning these autoimmune sort of itises because when we see someone in the ER, traditionally, if it's like patients on chemo, patients undergoing treatment for cancer, we're going to think they're at increased risk of infection. We're going to do a big infectious workup and we may start them prophylactically on antibiotics. Are these patients at increased risk of infection or not at all? It's more just the autoimmune side.
That's a great question. So truly immunotherapy doesn't actually drop your neutrophils, which is, you don't really have any neutropenia with most of these drugs. Sometimes you'll get a patient who, very confusing, is on chemotherapy and immunotherapy, a combination, because that synergistic effect for some cancers we think tends to be very good. So to answer your question, I think it's important, yes, these patients just by having a immunocompromised state and having cancer are more likely in general to be more prone to infections. Immunotherapy won't drop their counts as much, but my argument is just because they have cancer. So when you are suspecting a colitis or a pneumonitis, that's why we say when you're putting on those antibiotics, also consider to call us to ask us about steroids, which seems kind of oxymoronic. We don't like when we think someone has a rip-roaring sepsis or infection to give them steroids. And steroids, we haven't kind of gotten into that yet, but we consider these immune checkpoint inhibitor toxicities or related events, as we call them, to be medical emergencies. I think that's why when you came to me about what topic to do, I was like, this is the best topic that we should do, because they are considered medical emergencies, because the time frame to reverse these with the typical go-to drug for most of our toxicities being steroids is pretty short, because the patient's grade 2-3 can escalate to grade 4-5 toxicities. So we typically, when we get the call from the ER of somebody who's worried about an immune checkpoint related event, we tell them, yes, start the antibiotics. Consider something like COVID until the COVID testing comes back in this era. But also the steroids that we use is typically starting dose 1 milligram per kilogram. And so I'm in Alabama, 1 mg per kg.
Of prednisone?
Prednisone, yeah. So I'm in Alabama. That can actually be sometimes for our patients a larger dose. That kind of a dosage for at least a short amount of time until we figure out that this is not immune checkpoint inhibitor mediated, we think is fine to do as long as we're overlapping with antibiotics.
So pretty much, let's assume that you're practicing somewhere where you can't get in touch with heme-onc. I mean, there's certainly times where it's pretty hard. I don't have oncology at my hospital. So if you see a patient coming in, you've ruled out infections, you've sent off the C. diff, would you probably start them on prophylactic antibiotics and start them on steroids at the same time?
Yeah, I would. Especially the risk is higher when patients are on 2 different immune checkpoint inhibitors together. And that space that you truly see a patient on that is in the kidney world, in the kidney cancers, as well as the metastatic melanomas, and some lung cancers. So the thought process is, depending on the type of toxicity, the toxicity event rate is about, for single agent immune checkpoint inhibitor, about 2 to 5%, but it can go as high as even up to 25 to 60% when you have 2 agents on board at the same time.
Wow.
So I think, for most patients, let's say that this is 80 milligrams or 50 milligrams of pred, while you are doing empiric coverage, broad spectrum antibiotics. And while you, let's say that this is pneumonitis, have pulmonary keyed in that this patient maybe needs a bronch coming up sooner, you have the radiologist keyed in that, hey, when you type in the reason for the CT chest, I'm concerned about pneumonitis, particularly because of this agent. Then you can prepare to come off of those steroids quickly if you can find out that this is not what it is. That's for pneumonitis. For colitis, we typically keep the steroids on board until we can safely get the patient to a colonoscopy to see if there's really a lot of colitis in the scope.
Gotcha. And so would these patients normally be getting admitted, or is it something you would discharge them on steroids?
Yeah, I just had a patient this Friday who refused to get admitted. And so it's worrisome because they feel great typically with these drugs, and some of them want to be on these drugs for more than 2-3 years, which is when it gets hairy as to whether we should keep them on these drugs because of the toxicities. But the patient that I had just would not budge, felt like he could handle the diarrhea, wanted to take, it's just oral prednisone, right? So felt that he wanted to take it at home. Me and where I am in my training, and just wanting to be extra cautious, I typically, if we're going to manage an outpatient, call those patients daily while they're on the steroids. And then if there's not significant improvement, there are actually other 2nd and 3rd line drugs that we can use, which I'm happy to share, but might be a little too dense for this talk. And then that's when I'm calling that patient saying, hey, you're refractory to steroids, you got to come in. But if you have someone in the ER who is having 6-7 times diarrhea, and you're waiting for the C. diff, they're
probably going to get admitted.
They're probably going to get admitted anyway, being a cancer patient, being frailer or having problems. So I would just admit them.
Now, how emergent is it to start those steroids? Is that something like, oh, this is like anaphylaxis level, we got to put those steroids in right now? Or is this like, we should start this within the next 24 hours? Or, and do those steroids essentially reverse the
yeah, we want to start it within the 12 to 24-hour window if possible.
Gotcha.
But these things get missed all the time. So sometimes if it's been 2, 3, 4, 5 days, we still start it because we still think it could be effective.
Right.
So that window is more helpful when we start it, but some patients don't respond to steroids. They might be towards a higher grade toxicity. Yeah. And then the name of the game is actually some immunosuppressive agents to try to calm the immune system. And it does, to answer your second question, we think reverse the process a little bit to the point that when a patient is truly confirmed to have immune checkpoint toxicities, we give them such a long steroid taper. We give them sometimes 3-4 weeks of a steroid taper, and we typically say, we're not going to restart your immune checkpoint inhibitor until you are on the equivalent of 10 milligrams of prednisone or less, because then it just doesn't make sense because you're giving the immune checkpoint inhibitor and you're giving the drug to negate it.
Okay, so you would stop the immune checkpoint inhibitor.
Yeah, yeah, and that's a really, really tough conversation for some of these patients because depending on the tumor type, for metastatic melanoma, unless you have a particular mutation, immune checkpoint inhibitors are the go-to drugs. Less so for renal cell carcinoma, but if you have a patient who has a grade 4 toxicity and can no longer be on these drugs, it's a really tough and sad conversation with the patient that, hey, we have something super effective out there for you, but if we give it to you again, even one more dose, it could kill you faster than your cancer.
Right. Well, those are pretty much the questions I had. Is there anything else you think would be good to know about these immune checkpoint inhibitors, immunotherapy, and oncology?
Yeah, I think you touched on a lot of great stuff. I think when you are in the ER and you have 1,000,001 things to go to do, oncologists, we're really good at sitting and pontificating about a lot of stuff and looking at evidence-based medicine. But you guys are the ones, especially in this pandemic, who have to intubate and have to make quick decisions. So I guess my point to all this is it can be really stressful to try really hard to think, does this person have an immune checkpoint inhibitor toxicity or not, or an immune checkpoint related adverse event? And as you said, there are some hospitals that don't have oncology right at your fingertips. But I would say that if there's a hunch and you don't feel so strongly that steroids is going to harm the patient too much, it is something to consider starting. Sometimes when you start those steroids, man, you can get a response pretty quickly. And then you can kind of say, maybe this is what's going on. So I don't think it would be wrong at all. And I mean, cancer patients are very resilient and they actually respond very quickly as far as their fatigue and sometimes their mood. There's been lots of links to steroids being just good for them in general. So I don't shy away from steroids too much for my patients.
Cool. Well, thank you so much. This was awesome.
You're welcome. Thanks so much for thinking of me.